you, Dr. Janzen?
Great. Thanks so much. So welcome everyone. I'm so delighted to have this opportunity to speak with you tonight. I understand we have some parents joining from far and wide, so I'm really thrilled to have the chance to talk to you about neurocognitive impacts of childhood cancers and their treatment. So, of course, this is a big topic and it's very hard to cover something like this sort of in a 45-minute session or something of that nature. But I just want to give you sort of an overview of some of these issues, and hopefully we have lots of time at the end for questions. So I'm a pediatric neuropsychologist, and I work at SickKids, and I work with the oncology programs. And I encounter many parents who have questions about this topic, and that's why you're all here. So I just want to highlight some of the common questions that I hear and things that people are looking to a neuropsychologist for some answers. I'll provide an overview of what is a neuropsychology assessment, who might need it, what's involved, talk about some interventions and ways that we work around any cognitive or academic or emotional behavioral problems that are identified. And then, like I said, hopefully lots of time for discussion at the end. So parents often have questions about, will my child's disease or condition, will these treatments that are being offered, will they affect learning or memory or behavior? Why is my child having trouble concentrating? Is this something about sort of the treatment? Are they just really tired? Is this kind of who they might have been to begin with? How do we figure that out? Obviously, for so many kids going through treatment and with medical complications in general, kids miss a lot of school. And so parents are often wondering, they're behind, will they catch up? Is this going to just go back to normal once treatment ends and they're feeling better? Or is there something, have they kind of missed a window of opportunity? Is there some reason why they're not going to catch up? Parents will target specific problems, sometimes things like trouble getting words out to explain things, or specific cognitive problems, wondering, is this just normal for their age, or should I be worried? Sometimes parents are noticing quite a change in a child's emotional reactivity, crying easily. They seem upset all the time. They're not quite themselves. What's going on? Anxiety and anxiousness about, sort of medical things, or even, just everyday activities, noticing a lot of anxiety since the diagnosis and treatment, wondering what to do there. Or noticing that something a child used to be really good at, now they're not doing as well, and really trying to get a sense of, do they need special help at school? How do you access special education services? How do we even enter that world or know if we need to? So those are questions that I hear a lot, and I know from your group, we've got a lot of questions tonight. So I'm really hoping we can get to that. But yeah, I'm sure, from most parents' perspective, there's so many questions that are sort of, running through people's minds. So just to start with a neuropsychology assessment, like what even is that? It's a way of looking at brain systems and brain functioning sort of at one point in time. And then the intent is usually to do it, many times as the child develops, to see changes or progress. Sort of tests or assessment tools are done in a particular way, and that's so we can compare any child with other kids of the same age. And so what we're trying to do is actually take a snapshot or measure different aspects of thinking or cognition, academic achievement, and emotional and behavioral functioning. And that might involve direct assessment, so administering some tests directly to the child. Usually we're collecting ratings and different kinds of information from parents, sometimes teachers, sometimes the patient themselves. And that's usually around like emotional, behavioral functioning, social functioning, independence with everyday activities. And there's also a lot of consideration placed on the child's life and context, and what are the expectations, what's their environment, what are they supposed to be doing, or what do people want them to do. And so we're getting that information usually from interviews with parents, reviewing school records, medical records, talking to teachers, kind of talking to the child, really trying to get a sense of what are the concerns. Assessment measures then need to be interpreted, or that's sort of the art of it, is understanding the tools and the reliability and validity of the measures. We have to consider what happens when we give the same tests repeatedly to a child. There can be certain effects, on performance. We have to think about other things like fatigue and pain and sort of other factors, and really looking at a child holistically. So the different areas that are assessed have to do with cognitive functioning. And so again, those are sort of the brain-based skills that we're thinking about in terms of intelligence or language, verbal skills, visual, spatial, fine motor, and then these core cognitive functions. So here we're talking about things like attention, working memory, processing speed, and learning efficiency. So those are sort of, how does a child sort of, focus, hold things in mind, quickly manipulate information, and learn new things in an efficient way. And those are highlighted because those are the functions that are most vulnerable across, most childhood cancer survivors. Those are the things that we look at in great detail in a neuropsychology assessment, because that's what the research has shown are sort of the most vulnerable areas. And that's sort of one way that we're tracking change in kids who've had different kinds of treatments. But at the same time, we're also very interested in how kids apply these brain-based skills, or sort of their cognitive functions, to learning of academics. And so there we're thinking about, reading, spelling, writing, math. How do they actually apply sort of the thinking abilities to learning these new skills at school? What's the quality of their progress there? How is that going? And then the emotional, behavioral, adaptive areas have to do with sort of different aspects of behavior. So internalizing is like anxiety, sort of mood. How does one sort of manage their own internal emotions? Externalizing are behaviors you might see, like hyperactivity or sort of dysregulated behavior, oppositional behavior. We're interested in social functioning and coping, quality of life, and aspects of adaptive functioning or independence with everyday life skills. Can your child dress? Can they get ready for school? How much prompting do they need to get a snack or sort of bathe themselves or manage their bedtime routine? Those kinds of things. So knowing that about sort of what a neuropsychology assessment might encompass, sort of what are the different areas that are considered, it sort of leads you to wonder, like, well, who actually needs that? Not every child who has a cancer diagnosis or is receiving treatment needs, a full neuropsychology assessment. That's not true at all. We need to consider kind of the individual risk factors, or for any one child, what's their level of risk, or what does the research tell us about who's most likely to have these kinds of challenges or need, comprehensive assessments. And so here we look to different sort of guidelines and standards of care within pediatric oncology. And, a lot of the thinking has been that children who are at the highest risk of having neuropsychological impairment, they're the ones who probably need the most sort of service or the highest level of comprehensive assessment. And so those would be kids who have, been treated for brain tumors, or perhaps other tumors in which radiation includes the brain. So sometimes there we're seeing kids with different sarcomas or tumors that affect sort of the facial structures or the eyes, different tumors of the face or skull or ear. Those would sort of count there. Or we're thinking of kids who've received central nervous system directed treatment. So there often it's the leukemias and the lymphomas who've had neurotoxic treatment. We're especially sort of focused on high dose methotrexate. There's a lot of research on the different chemotherapy agents, right? And of course, no one chemotherapy drug is really ever used in isolation. They're almost always used in protocols where there's multiple agents. But we do know that in terms of neuropsychology risk, methotrexate is certainly one of the players that we pay a lot of attention to, and the age at which the child received it and the dose. So we're also considering then what kinds of neurological complications might a child have had during their treatment. So again, if we're looking at brain tumors or leukemia, lymphoma, thinking sort of, well, what happened? Did they have seizures? Were there changes on brain imaging? Or sometimes we're thinking about, for example, kids with neuroblastoma who are at risk for something called like opsoclonus myoclonus syndrome. So that's, again, a sort of neurological complication of their disease. But we're also really considering pre-existing conditions. Who was this child to begin with? What kind of functioning did they have to start with? Did they have perhaps an autism spectrum disorder prior to their diagnosis of cancer and then sort of the treatment, or children with leukemia who have Down syndrome, or children with particular brain tumors who have neurofibromatosis type 1 or NF1. So again, really considering developmental and neurological conditions that pre-existed the cancer treatment and what impact that might have had. So those would be sort of our highest risk groups. And I'll just share a little bit more about some of the different treatments and what that means for neurocognitive risk. So cranial radiation, like I said, is certainly one relevant risk factor. And again, what we know is higher doses at larger volumes of the brain at a young age, those are children that, almost uniformly would receive neuropsychology assessment. We know that photon radiation is intended to be sparing to some degree in terms of cognitive functioning, and a lot of the research is bearing that out. But we also want to be very aware of where was the radiation directed, at what dose did certain sensitive brain regions receive radiation. We often are looking at the mapping, trying to see sort of the hippocampus and what was the dose for that particular area, because it's very involved in memory functioning, for example. So we can really sort of hone in on very specific kinds of exposures and look at cognitive functioning related to that. Within the chemotherapies, different agents, like I said, methotrexate is one that there's a lot of research typically showing, attention problems are related to methotrexate, and that's part of, almost all leukemia and lymphoma protocols. We worry about the cisplatin in terms of hearing loss, and often children are monitored with regular assessment of hearing. Vincristine and fine motor difficulties, that too is something that's being monitored, and especially when there's peripheral neuropathies or trouble with nerve endings related to vincristine, that's something we're looking out for. But just in general, steroids, other combinations of treatments, those are all sort of things that would be looked at very closely and considered in terms of level of risk, or sort of what was a child exposed to. The child's age is really important, and in general, we would say younger age at diagnosis is related to poorer neurocognitive outcomes. The brain, as it's forming and developing, has, there's potential for neuroplasticity for sure, but also there's a lot of vulnerability in very young brains that haven't yet sort of fully developed the myelin, in particular, the sort of white matter, or the coating that is meant to sort of cover neurons and speed conduction within the brain. So one of the main mechanisms of damage for children who've received chemotherapy, it has to do with sort of white matter and white matter development. And we know that's very highly related to children's age. And so in general, we can say for neurocognitive effects, there can be a cumulative effect. So the longer you are from the end of your treatment, the more likely there might be something that can be seen on assessment, or there's more likely to be trouble the longer you wait, or the further out from treatment you are. So just to give a bit of a schematic of some of the things that are considered, obviously we have the diagnosis and the disease itself. We have all of the treatments and sort of what was entailed in the treatment, any relevant complications. Then we have aspects of survivorship, or just sort of what's a child's health quality like, what's their lifestyle, are they receiving any interventions, how are they coping and managing with these different factors? And then, of course, sort of family functioning, sort of access to different services. All of those things are really relevant. So again, kids are looked at very individually in terms of what's their environment, their context, what has been tried, how are they working around different challenges they might have, if any, and what's available to them in terms of supports or interventions. So within a comprehensive neuropsychology assessment, again, it's really a matter of looking at different patterns of strength and weaknesses. Sometimes diagnoses are offered based on the assessment. And so those might be things like intellectual disability diagnosis, or a specific learning disability. If a child's having a lot of trouble with math or reading or writing, that might be a diagnosis offered. Sometimes it's more attention deficit hyperactivity disorder, or sometimes we're picking up on mood or anxiety disorders. For young children, I see a lot of kids with separation anxiety, and that's really, fairly common when kids are diagnosed and treated at a young age, and separation from parents becomes very, very stressful. Other times we're picking up on other conditions or things that might warrant further investigation, or sort of looking into other diagnoses that might be relevant. But what we're really hoping to do is address any areas of weakness or need that are identified. We share this information with the medical team and the school team. That's why kids are referred, is so that we can sort of have something to go on in terms of what their needs are. Often medical teams are very interested in cognitive functioning and looking, from a research point of view, in terms of what are these treatments doing long term in terms of neurocognition. We're often, I spend a lot of time working with our school liaison or interlink nurses around supporting children as they return to school, making sure if they have individual needs that those are addressed. Sometimes there's referrals to different hospital or community partners for rehabilitation. It might be for more mental health services, and at least at SickKids, we have a health psychologist affiliated with our team. And so sometimes it's a referral internally to somebody who can offer treatment. So for example, if there's significant anxiety, that might go on for more direct intervention from a health psychologist. Other times there might be a real clear need for medication consultation. That might be related to a diagnosis of ADHD or very significant attention problems, or it might be more for mood or anxiety problems. So again, psychologists, I'm a psychologist, we don't prescribe medication, but there might be times in working with families that it's clear that people would at least like to know what their options are in terms of medications for treatment. And that's when we would refer to psychiatry for consultation. But, most commonly I hear from parents, they don't want any more medication ever. That it's just like, no, we're done with all treatment. We're done with medication. Don't want to even consider it. But when problems are really severe, then sometimes that is part of getting some education about that. And often, I'm involved in things like documentation for disability benefits or paperwork for specific accommodations as kids maybe transition on to college or university. Sometimes we're even completing paperwork related to program eligibility, like for Developmental Services Ontario or other programs like that. Sometimes that's what we're trying to help with is getting access to services through sort of documented reports and detailing what the needs are. So what happens if there are some difficulties in any of those areas, either sort of cognitive or academic or emotional and behavioral? It's pretty clear that something should be done, and like what really works. And so there's a lot of focus on school-based interventions sort of off the start, and making sure that kids have access to appropriate accommodations. Sometimes it's actually curriculum modifications. So it's saying, okay, this child's in grade 5, but what we need is modifications to, let's say, a grade 3 level for reading, or, scale it back because we want to see them be successful. Often class placement is considered for kids who have quite significant needs, wondering, is there a better placement or a different way to educate them that would be more appropriate. And within school systems and special education services, some students are identified as having, exceptional needs. And there's sort of a process within school boards for doing that. And often that's based on a detailed assessment, like a neuropsychology assessment. Some students or some of our patients require services from itinerant teachers, and that could be for vision or hearing or sort of specialized sensory needs. And school boards, in most public school systems, have access to very specialized teachers that can come in and help with that. In situations where it's more about anxiety or behavior challenges or coping, sometimes we're requesting school services in the form of social work or child and youth worker, or at the high school level, that might be a guidance counselor. Often we're asking for things like just common sense, like this child is fatigued and gets overwhelmed in a busy, noisy classroom. What we're looking for are rest areas or quiet places for them to kind of just rest a little bit. They're still recovering. Or sometimes increased supervision. Some kids really do require sort of more supervision, and that might be because they're fragile medically, or have specific needs, or perhaps seizures or different things that require more direct support from adults in the school setting. But this is really meant for you as parents to think about, well, what else? Like, let's say you don't have sort of needs at the level of specialized school services. what can you do at home or just on your own? And so, I emphasize a lot with families, you do what you can, and really try to reinforce any skills that kids are learning at school, really trying to encourage them with just additional practice of the same concepts that they've learned in the school day. That's something that I think, really can go a long way, is just working with your child or slowing things down a little bit as you review the schoolwork or whatever was done. If you are able to access that, looking at any homework or worksheets, and really trying to just practice and slow down and explain it again. For most kids, it's just about sort of using daily life activities to teach, basic sort of reading, math, spelling, writing, and really encouraging social skills. For so many of our kids, they just haven't had the same social opportunities or the chance to interact with peers. And so many benefit from just sort of gentle coaching a little bit on how to handle different social situations or how to respond, as they're sort of building up their practice there. I think at home, really, for a lot of kids, their behavior, they can benefit from a lot of just routine and structure and consistency. Again, that's something that kind of just goes right out the window during treatment. And as much as it can be, trying to sort of resume that whenever it's possible and provide some of that for children, it really goes a long way in terms of their comfort level and helping to kind of help cope. Planning and organization, for so many kids who struggle with some of those core skills like attention and holding information in mind, they find it really hard to sort of plan and organize, to break things down into small steps or figure out where to start. If they're asked to do a big task or a job, it's hard to even know where to begin or estimate, how do I do this? How long is it going to take? What am I even trying to do? Am I on track in reaching my goal? Those are sort of high level skills that for some kids, they really need to be taught how to do that, and sort of everyday things like cleaning your room or planning a birthday party. It helps for them to sort of see an adult work through that and talk them through how to do these things. We really want to see families providing a lot of emotional support, encouraging kids around sort of reassurance. Again, knowing that anxiety can certainly be an issue for lots of kids during treatment, really trying to support kids emotionally and help them to sort of regulate and deal with whatever emotions they have. But we also encourage regular physical exercise as soon as it's possible, to try to get kids sort of doing cardiovascular exercise. And that's for a lot of reasons, but there's some really exciting research that's been coming out in terms of cognitive or sort of brain repair post-treatment, showing that, physical exercise may be one way that we can help children who've had cognitive difficulties because of their treatment. It's been particularly looked at in kids following cranial radiation. But we also know regular physical exercise is really good for sleep and for mood, for appetite, sort of all the other things that you want to see as part of a healthy, balanced lifestyle. For some children, sort of like I said, more specific interventions might be recommended, and in many cases, following a neuropsychology assessment, we're then looking at trying to intervene around some of the emotional and behavioral aspects, and that might include things like behavior therapy, cognitive behavioral therapy. That's one therapy approach that's very effective for treating mood and anxiety problems in kids and teens. There's something called the problem-solving approach, which has been trialed in kids who are cancer survivors, really trying to help them approach everyday problems, just like I said, by breaking them down, sort of figuring out what are the steps, how am I going to deal with this, sort of teaching a very practical problem solving approach. And that can really go a long way in terms of coping and feeling like kids have control over their situations. Mindfulness-based stress reduction is another thing that's been looked at a lot in this population, really encouraging kids to do activities that help to decrease anxiety. Certainly support for parents is essential, and joining organizations like this and other avenues for support, whatever works, in your life, that's really essential, because we know, very clearly that the more parents are able to cope, the more their children can cope with difficult circumstances. And often rethinking some of the expectations for kids, at least, during a time of treatment, rethinking some of the attributions. A lot of the times, for kids that I'm seeing who have cognitive difficulties, I really want to encourage parents to move away from, attributing kids, just to not trying, or they're not working hard enough, to sort of recognizing this is legitimately very challenging for them, and here's why, and let's think about sort of how hard they might be working just to sort of, be functioning at the level they are, and what's reasonable in terms of expectations for them, like at school, for example. So you might be saying, well, okay, fine, that's interesting, but what about some of the kids who maybe aren't considered high risk for these neuropsychological deficits? What do I do if my child sort of hasn't been offered any neuropsychology services, or that's sort of not the direction to go, but maybe I still have some concerns, or I'm still wondering about certain questions that were raised at the beginning? And so there, I'm really encouraging people to think creatively around what can you access? What are some of the resources? How do I sort of communicate the concerns I have? Speaking with your child's oncology team is probably the number one place to start, and share those concerns and try to figure out at your center, wherever your child has their medical care, what's available, what do they recommend, how do we access, supports through the school, and using sort of all the players and supports that are available. And so I always direct parents to About Kids Health. That's the SickKids website, that has a lot of really great information for families on late effects, emotional impacts of childhood cancer treatment. Again, speaking with the school team is essential if you have concerns about your child's learning, or you feel that their sort of educational needs are not being met. That's really a conversation to have with the school principal. And at least at SickKids, we often have our interlink nurses provide support for families where they just haven't been able to attend school, or there's other factors related to sort of the physical needs at school, and really trying to support, at least sort of having the principal of the school know what the needs are, or what the concerns are of a family, and help them address those. Of course, organizations like POGO, Pediatric Oncology Group of Ontario, and OPAC, and there's so many different organizations, but really your oncology team is the hub, or the place to start in terms of getting access to supports and services, and sort of finding out within, each of your centers or your countries or contacts, sort of what's available, and getting links to the kinds of services that you might need. So just to shift gears a little bit, I wanted to share with you something that we're doing at SickKids in association with our colleagues at St. Justin in Montreal. We have a study that we've just started, actually, just sort of early enrollment, but what we're hoping to do is offer some cognitive screening across all of pediatric oncology. So this is eligible to all childhood cancer survivors, not just those within those high-risk groups. And so this was sort of thought through because, we recognize there's some gaps in terms of service. And we also really want to develop sort of quick screening measures to help us to know, okay, well, who might need more follow-up, or how can we sort of quickly screen and identify kids who might need more service versus those who are just fine and really don't need anything at this time. And so it's really about looking at different measures and sort of how accurate are they in identifying cognitive problems within our pediatric oncology population. And so, just like I said, right now, most of the referrals that come to our neuropsychology service, they're coming from oncology clinics. And usually it's because the child's disease or treatment has put them at high risk, and because a parent has reported some kind of concern. So that doesn't include everyone, though, who might legitimately need services. So we're really hoping to identify sort of other screening tools or ways to look at this in more detail. And so this study involves working, individually with a child or youth. They complete an assessment, a brief assessment of cognitive skills in a questionnaire. Parents are asked to complete some different rating scales and provide some information about their context at home. And teacher participation is optional. They can provide some ratings, but they don't have to. And all the participants receive a gift card and just a brief report outlining their performance on the measures in the study. And so this study is including all patients who've had pediatric cancer treatment at SickKids, or not necessarily at SickKids, but are willing to come to SickKids for this study. They have to be between 8 and 16 years of age. That's based on the measures we're using, at least 1 year post-treatment, not receiving any current treatment for any other reason. Children need to be English speaking for us to use the test measures that we're actually testing. And both the child and a parent or caregiver need to agree to participate. And so that's something that we're doing right now, and we're hoping to continue enrollment on that study for the next year or so. So if you're interested, here's the contact person. It's Bethany Lerman at SickKids. So I think I'm going to stop here and try to get to some of the questions. I know that we have lots of questions already compiled, and let's see if we can have a chance to take a look at some of those. I'm not sure if there are any additional questions in the chat.
Not yet, but if thank you, Dr. Janzen, by the way. Great presentation, very informative and interesting. And we're opening it up to questions now. If you'd like to have a question for Dr. Janzen, you can type it in the chat. And I do have some other questions people have submitted in advance in case nobody has any questions, but I'm sure they will.
For sure.
Yeah. So maybe while people are thinking about it, I can start with asking some of the questions that we received in advance. The first question was, how long can the effects of chemotherapy last on the memory?
Yeah, so I mean, for some, again, there may be variability, or it may depend on which chemotherapy agent we're concerned about and tracking. When there's, in some children, the effects might be long-term, and it's really a matter of working around those impacts or compensating for those difficulties. It really depends. So things like your corticosteroids, which are part of many chemotherapy protocols, those effects on memory are often quite short-lived, right? Those are, corticosteroids are things that you'll see often: some behavior changes, irritability, mood changes. There can be memory changes. Again, it sort of depends on the dose and something that we monitor there, but those are thought to be sort of temporary. But some of the other effects on those core cognitive functions in kids, for example, that might have had high dose methotrexate, those are thought to be longer lasting, and they may not sort of go away on their own. We'll need to accommodate for those.
Thank you. There was a parent asking about her child. He had high levels of methotrexate. He was affected, it affected his ability to learn and retain subjects like math and science. He's in post-secondary now, and he needs to take a science course. And mom was wondering about post-secondary institutions. Do they have exemptions made in cases like this when they're at the university or college level, if they need an exemption?
Yeah, so that's often something that a neuropsychology assessment would help with. Is what's needed there is documenting the cognitive problems. So it's not just saying, they're struggling in science. It's really going back to, well, maybe that there's a memory problem in general. It's affecting them in science right now, but what we need are accommodations, memory aids, those kinds of things. And so, having a formal neuropsychology assessment or psychoeducational assessment, that's the kind of documentation that's needed to have a person in college or university be considered for accommodations. And specific memory accommodations are one thing that they could access, but there's actually lots of things that students who need accommodations in their university or college program can get. But to sort of get in the door, you need some kind of an assessment, and then it's reviewed, and then there's support services available.
Thank you. In the meantime, if you have any questions, just type them in the chat and I'll stop reading the ones I have here. Okay, in the meantime, a parent had a question. Her child has a brain tumor, had partial resection surgery, and they're seeing cognitive and behavioral changes. Are there any studies looking into such effects in kids who have not had radiation or chemo?
Yeah, so kids who are treated for brain tumors just with surgery only, right? That's
Right.
like what's being described. Yes, there certainly can be some cognitive impacts of that alone. So there you're thinking of what was the tumor, in what area of the brain, how much impact did it have on sort of surrounding areas, right? For a lot of kids, the tumor itself is causing hydrocephalus, or like pressure within the ventricle system of the brain, and that's not great if it's sort of going on for a long time in terms of cognition. So yes, there can be impacts for kids even who don't have chemotherapy or radiation, but again, it depends where in the brain the tumor was, and sort of what were the downstream effects of that. What functions did it impact? But yeah, that would certainly warrant neuropsychology assessment if that was available.
Okay, thank you. Someone was asking, is it usual for preteen children to develop depression, anxiety, and PTSD years after completing treatments?
I would say we usually see that most commonly kind of closer in time to the treatment, or the time that they're sort of going through the experience, and where things are so sort of out of the ordinary. To develop it sort of years later, I think that's something I would expect is less common. But I think once in a while there are children who have gone through something and they were young, right? And they didn't really fully appreciate what happened to them at the time. They didn't know, like, sometimes we'll see really young kids, and later on, they don't really know a lot about sort of what happened. They just know that they came for a lot of different medications or treatment, or came to the hospital a lot. But what they do know sometimes is that whatever it was very distressing to everybody else, and kind of perceive that whatever was going on was not good because other people reacted to it in a distressing way. And sometimes I think that is something that would be remembered longer term than the actual experience. But yeah, in that case, I'd really be looking sort of, at sort of what's the meaning of this for this young person, what do they attribute this to, or sort of what else is going on. Or sometimes it can be that experience, and then let's say the loss of a grandparent from cancer or something that then sort of triggers, oh, I think I had something like that, or you know what I mean? Like it's often considering in detail what's the meaning of this when something happens years later, sort of beyond the scope of time that we would normally expect it.
Okay, thank you. We have some questions now in the chat. Question from Stephanie. In your professional opinion, do you think there could be a correlation on siblings having cognitive challenges due to the trauma experience with their brother or sister on treatment? And if so, what is the best way to advocate for supports for the siblings?
So I would say in general, I wouldn't expect siblings to have cognitive challenges like with memory or attention or thinking or, language related necessarily to the sibling who's on treatment. Like that I wouldn't anticipate. They might have emotional or behavioral changes, but I wouldn't necessarily expect cognitive changes, right? Those are sort of, that's a little bit different. But when kids are having emotional and behavioral changes, then for sure we want to see them getting help. And yeah, I think often our team social workers are offering services around for siblings and for siblings around coping, for dealing with sort of all the things that happen if you have a brother or sister who's unwell for a long time. Really trying to help families, find ways of navigating that and still meet the needs of siblings while caring for their ill child. But I wouldn't expect the sibling to have cognitive problems. I think more likely it would be emotional or behavioral and coping, or maybe they're sort of challenged in school to begin with, and then it's just not sort of noticed in the same way because all the attention is being paid to a brother or sister who's ill. That can happen too, I think.
Thank you. A question from Shane and Dana. If a child received treatment, chemo radiation at age 7 or 8, chemo again due to a new cancer at 15, had an assessment going into grade 8, would the assessment need to be redone prior to starting university or college?
Probably, yeah. So a lot of university and colleges, each university is a little bit different, but usually what they're saying is if you're asking for accommodations based on cognitive or learning problems, they want to see assessments done within the last 5 years. And so usually there's a window of time that they would like to see assessments completed. And so, yeah, I think if the last one was going into grade 8, it would likely make sense to have another one sort of at the time that they're applying for universities or college.
Okay. Question from Amanda. At what age can the neurocognitive assessment be done? My son is 4 and just completed high-risk neuroblastoma treatment. We were bringing him to a cognitive behavioral therapist, but found he wasn't getting much out of the treatments. He has been displaying separation anxiety and some memory and motor issues since starting school in September. So at what age could he get the assessment done?
Yeah, so we'll certainly see kids who are 4 because they're usually in JK, they've started school, they're already sort of in learning environments. And if there's supports needed, it's so much better to get those in place early rather than later. And it, if a child is well and they're sort of stable in terms of their functioning, then for sure we could see a 4-year-old. Yeah, I think it looks like not getting a much out of the cognitive behavioral therapy, it might be a little bit early for that kind of treatment, because kids need to verbalize a lot of how they feel and what they're experiencing, and that can be hard. But there certainly could be an assessment at 4 of a child's overall intellectual development, sort of language and, visual spatial thinking speed. How are those sort of early literacy and numeracy skills starting to look, and what their emotional and behavioral regulation is looking like at that age. Yeah.
Thank you. So I'll ask a question from before. Are there any studies on neurocognitive development in children treated with TKIs?
Yeah, so that's a very new area. And it's sort of always the case that new innovative treatments in oncology come out, and then sort of this kind of research on neurocognitive impacts, it actually takes years to sort of collect information and look at long-term effects. So honestly, I haven't seen a lot of research yet on TKIs. Yeah, there's usually, many, long period of lag time, but that's always of interest once we start to see groups of kids being treated on sort of new agents or new protocols, then starting to group them together and look at longer term outcomes. But again, neurocognitive outcomes, the things that I'm most interested in, or that families, want to know about, it's often 5 years post the end of treatment, 10 years, 15 years. People want to assess and monitor kids in this kind of research, very long term, and so it can take a long time for good studies to come out.
Yeah, that leads me to another question somebody had about interested in studies that look at the long-term effects beyond 10 years post-treatment. So
Yeah. Yeah, and there's a lot of really nicely done literature now on different disease and treatment groups, right? You'll see, like, what are the long-term impacts, let's say, of leukemia treatment or brain tumors or specific other cancers, and or certain kinds of protocols. Our colleagues at St. Jude's in Memphis have published on huge cohorts of long-term survivors. Now we're talking about people treated for pediatric cancers who are now into their 30s and 40s and 50s, right? So very long-term. And so yeah, there's definitely research that is focused on them and sort of what are their needs later in life, and monitoring all sorts of health outcomes for that population of long-term survivors.
okay, great. Thank you. And there's a question from a mom who wanted to know, here's the question. Her son struggled at school prior to his diagnosis, and the school did an assessment at that time. Once they found out he had cancer, they nulled the IEP on the basis that it wasn't accurate. And a year and a bit after being in remission, they refused to do another assessment on the basis that he is not in school full-time because of his appointments. She doesn't feel this is acceptable. What can she do as a parent to advocate for him?
Yeah, so no, I agree with you. That doesn't seem doesn't seem fair. Start with the principal and really try to communicate the concern. If a child had an IEP before, yeah, maybe it's not sort of accurate anymore, but probably those things haven't gone away, right? And really starting with the principal and then trying to escalate if that doesn't work. Your next step up is your school superintendent, and they oversee sort of at the board level. There's different steps up in terms of trying to advocate when there's educational issues and concerns, but speaking with the principal and at the first place, sort of directing it at that level, that's really the best bet. And again, if this child is in a program that has an interlink nurse, that's often a good place to request some advocacy around a school meeting, or a specific meeting to address the concern, or just to have a little bit of backup from your oncology program to say, hey, we're concerned and we would like this taken seriously.
Shane and Dana here on the chat said, we had the same issue with our child. The wait time through school board locally is years here in Peterborough, and that's hard when your son is aging out of high school in pediatric care.
Yeah, I know it's a huge problem, is sort of under resourcing of different kinds of services. And one of those is psychology services within schools and within hospitals, and wait times are often unacceptably long. I think all that can be done is try to advocate, try to communicate what the concern is and the need. And yeah, I think getting services from psychology at the pediatric level, sort of before they transition out, is really important, because once they're into adult health services, I think there's even less. But there's also sort of private options that if people have resources or insurance, that may be an option. Or sometimes there's other creative ways of accessing maybe even a sort of more basic assessment, like a psychoeducational assessment rather than a full neuropsychology assessment, but that might help to meet the needs and get them at least what they need into college and university.
Jennifer had a question in the chat. Our child was not able to complete the neuropsych, he is 9, due to cognitive challenges. We will attempt again in a year's time. What do we do if he still can't complete it? Are there any other means of assessment?
Yeah, so I'm just trying to think about sort of what that would mean, like to not be able to complete due to cognitive challenges. Like typically most of the kids have cognitive challenges, or that's often what the reason for the assessment. It doesn't sort of mean that. Usually there can be some approach to assessment or some documentation of the needs, even if a child isn't able to directly engage in testing. And so I guess that's why I was trying to sort of give an overview that sometimes some of the children I see, for example, are very severely impacted, and some children for different reasons are nonverbal or not able to sort of engage in direct kind of question and answer activities, or maybe only have very short periods of time that they're able to. But there we rely a lot on observation or ratings that are provided by parents and teachers around the child's capabilities and development, or reviewing school records or talking to teachers. Usually we can derive something of value or something that would help to guide supports and interventions. I think it's pretty rare that a child is entirely not able to be assessed at all, or not able to have some review of their cognitive functioning that's meaningful and helpful.
Okay, thanks. There was a parent who asked about a total body radiation and chemo that her child receives before they were 4 years old. It's part of conditioning for transplant. She wanted to know, when did the neurocognitive side effects start to emerge, or how soon after transplant do you see the side effects? And how soon after transplant and resuming school should a child be assessed?
Yeah. So typically the total body irradiation that's done pre-transplant, it's part of the whole conditioning regimen. Usually the radiation dose for that is 1200 centigrade, or sort of what I would consider a low dose radiation exposure. It's whole body, but the brain is getting a much lower dose than would be given if a child had, say, very high risk leukemia or a brain tumor. At that dose, it certainly is worth monitoring them, but on the plus side, that's considered a bit of a much lower dose than with some other conditions. But I think the issue about transplant is they've already had a whole round of treatment for the disease that brought them to transplant. And so really trying to see again, what was that treatment? What were the complications? What did that look like? Post-transplant, if we're going to see changes, there's often just, an accumulation already, right, of the prior chemotherapies, and then sort of what's happened during transplant. I mean, within about 6 months, I think it might be worth having an assessment, or at least take a look at how a child is doing. Because by then they've certainly resumed school and normal activities and regular kind of programming in life. So I think that would make a lot of sense to evaluate around that time if a child's feeling well.
That parent also it was a multi-part question, but her final question there was about, do children who receive these total body irradiation high dose chemo before 4 years old ever be able to finish university degrees, become professionals, and live normal lives?
Yeah. I mean, that's a hard one, right? Because I wish I would know sort of what's going to happen for any one child, but of course I don't. I think, yeah, the range of outcomes is amazing, and we'll often see kids who, yeah, of course, go on to college or university and have professional lives and have just done very, very well. And so, yeah, there's many factors that go into that, and it's more than just cognition for sure. But yeah, I think in that case, parents, of course, should have the expectation that their child is going to do well and do the things that they want to do in life, and sort of work on the basis that they're likely going to get to where they want to be. It might take a little more work or a little more support, but yeah, I always try to encourage parents to think really optimistically about what those outcomes could be, because we can't always predict, and sometimes young people just amaze me.
Good to know. We have just time for a few more questions. Of course, feel free in the chat. If not, I'll keep asking because we have some more here. While people think about it, are there any predictive factors that dictate how severe cognitive and behavioral effects and what kind will develop? Are there any predictive factors that dictate this, how severe the effects will be and what kind of effects?
Yeah, so like I said, that's actually a very complex sort of science, right? Related to who was the child before, right? Like what was their functional level? What were they doing? Were there any issues or difficulties before? What was the disease, right? Like pediatric cancer is not one thing, right? It's many, many, many things. And the treatment is dictated by the condition and the disease. And so again, reviewing all of the complexity of what was the disease, what were the potential impacts, what kind of treatment did they have, what were the complications during treatment. Again, there can be so many different neurological complications from treatment, all the way from sort of neurotoxic conditions to stroke to seizures to other things. How long did the child miss school? What else happened? Sort of, again, it's very individualized because it's actually very complex, and that's what makes it really hard to make predictions. But yeah, there's many, many, many predictors, including the age of the child, and then sort of all the things that were done for intervention, right? So what kinds of services and supports did the child get? Did they get any rehabilitation services? Do they require any other sort of pharmacological treatments and interventions? All of that plays into sort of their long-term outcomes and functioning. And so the models of predictors are like so many different things to consider.
Thank you. There's one parent here who was asking, their child is post-chemo and post-proton radiation. They were diagnosed with ADHD and OCD, the onset of which seemed to be during chemo, and they want to know how they can best mitigate the struggles that he has, long-term resources for them. Short-term therapy is in progress already. They're trialing ADHD medications, but for long-term resources to help him.
Yeah, so it sounds like there's a few things going on, or a few different areas that could be the focus of intervention. And Yeah, it sounds like probably, there's some cognitive risk factors or reasons to want to assess that or look at sort of strengths and weaknesses there. Um, if the ADHD is managed with medication, that's great. OCD, though, can sort of be the loudest problem for a period of time. When it's present, often it can be quite distressing and interfering in daily functioning. So getting sort of the most effective treatments there, usually cognitive behavioral therapy or sometimes medications like SSRIs, the selective serotonin reuptake inhibitors, are very effective for OCD as well. But really thinking long term, it's about having sort of adequate management of medications, access to sort of therapy, access to school supports and services if that's needed based on whatever the cognitive issues might be, and really trying to provide the level of support and structure. And not lose track of the fact that no kid can do therapy and intervention all the time, right? So when kids have multiple challenges or sort of different things that are being worked on, of course, remembering like, they can't spend all their time trying to remediate cognitive problems and learning problems at school and get treatment for OCD and manage this, right? Like there's got to be some fun and some good times in there too. So trying to find balance as well.
I just have two more questions
Yeah.
for you from the advance, and then unless there's somebody else here, we'll finish up. I think this one you already kind of answered in your presentation. What chemotherapy agents are related to neurocognitive changes? And you did mention some of them.
Yeah, so methotrexate is the most highly researched out of all the chemotherapy agents, but like I said, there's many agents, and they're never used sort of one at a time or one only. Often they're used in combination. And so, yeah, I think, when I work in what I do, I'm constantly doing literature searches on every chemotherapy agent because I want to know, is there new research coming out on that particular drug? What do we know now? Maybe like things change really fast. And so, yeah, I think there's no one culprit in terms of chemotherapy, and no two kids respond in the same way, right? So you can have the same chemotherapy protocol. One child will have sort of really adverse reactions to that and have a high level of side effects and complications. Another child won't. And so again, it's what are the agents, but also what were the complications? How did their body sort of, tolerate those agents?
Okay, thank you. And the last question I had here was they wanted to hear your thoughts on neuroplasticity.
Yeah.
Any thoughts on that?
Oh, I got lots of thoughts. That's a great question, but yeah, it's actually very complex. So neuroplasticity is referring to sort of the capacity of the brain to compensate or reorganize or sort of adapt to different kinds of insults or changes. Or neuroplasticity is actually the mechanism by which we learn new things and establish new patterns, right? If I suddenly am able to learn Portuguese and learn how to speak and write and communicate in Portuguese, that's reflected in neuroplasticity because my brain changes as a result of that new acquired knowledge, right? So neuroplasticity, mostly though, people think of it in relation to young children and the fact that when there's an insult or injury, neuroplasticity can allow certain functions to reorganize in other areas of the brain to sort of spare or preserve cognition. So a good example is children with early seizures in kind of the left temporal area of the brain where language should be developing. If it's impacted or damaged in some way, language will develop elsewhere and preserve language. And so neuroplasticity is really relevant, more like for focal injuries or when there's something in a very specific area. The sort of downside of chemotherapy effects are that they're not focal, they're diffuse, right? The entire brain is exposed to chemotherapy. It's not just sort of one little region or one area of damage or impact. So, I mean, yeah, I think it's working at many, many different levels, but we can think of it in terms of neuroplasticity related to insult. It's not quite the same for these kinds of neurotoxic effects as it would be for like a stroke, for example. That's very focal or just one area of the brain impacted. But when we think about recovery and things like exercise as an intervention for cognitive, recovery after radiation, that's something that's being looked at from a neuroplasticity approach in terms of regeneration of hippocampal brain cells. And, that is the explanation for how there might be recovery. So yeah, neuroplasticity is complex.
Well, thank you for your thoughts
Yeah.
on that. And just to wrap it up, I know a lot of parents have the same version of the same question, how can they advocate best for their child? And I think what you mentioned, the first steps are good resources are the interlink nurse and also their school team. So those are good places to start with that. And yes, people are thanking you for sharing your knowledge and expertise this evening. Thank you. Also, if you're interested in participating in Dr. Janzen's study, when you view the presentation tomorrow, there's the poster. We've been posting it on OPAC's pages as well. It's on our website studies page too. So very important if you'd like to participate to follow up with that. If you need a link to it or a poster, I have it at OPAC, info@opac.org. I can share it with you as well. And of course, like Dr. Janzen mentioned, it's important for parents to reach out to each other for support and help. And that's what OPAC is here for as an organization. For more information, you can visit our website, opacc.org, for all our support services. And sign up as a member if you're a new parent on here who's not yet an OPAC member. It's free to sign up to access all our programs and services. So thank you very much. We'll share this link to the recording with our attendees tomorrow. And thank you, Dr. Janzen, for such an informative, wonderful presentation tonight.
Lovely. Thanks so much to all of you.
Thank you. Good night, everybody. Thank you for coming.
Bye.
Bye.